So welcome everybody. It's a real honour and invitation to have this opportunity to speak to you today. Probably my second ever visit to Poland. First time to, does it still count as Warsaw, or are we just outside Warsaw? It's as close as I've ever been to Warsaw. I managed to survive flights yesterday with Ryanair and EasyJet on the one day. So I feel I've done well to get this far. So we're scheduled for quite a long session this afternoon, quite a lot of pathology to talk about. I think to make 3.5 hours manageable, this needs to be interactive. You don't want to listen to me talk for 3 hours. But I do want to say to please feel free to interrupt me at any stage. I will try and gently ask questions. Don't like to see the front row empty, that's a bad start. Maybe I'll take those seats and put them at the back, I don't know. But I want to also say that I know that I don't speak any Polish, so we unfortunately have to communicate in English, and I know this might be a challenge, especially maybe with the Irish accent, might make it more difficult, so I will try and talk as slowly and clearly as I can throughout. Please let me know if you want me to talk slower or if you want me to talk faster, whatever makes it more easier for you to understand. So please don't, I don't want to be at the end of 3 hours saying, how was that? Sorry, I didn't understand what you said. So, we have revised our timetable, and I thought it might be useful to split the proceedings up into first half before coffee break, exclusively on macroscopic specimen assessment. How do we handle specimens at a very, very practical level? I want to know what you do at the minute. I tell you what I do, and we'll see how they compare. It was also very useful to get from you some idea of protocols that you're currently using to assess these specimens. So thank you very much to those who submitted those. It gives me a real nice idea of what the current practice is, and similarly for reporting that we'll address in part 2. So before the coffee break, it's going to be all macro. After the coffee break, all micro. So microscopic reporting of colorectal cancer as things stand. But we do it in that order. But do feel free to interrupt at any stage, stick a hand up, ask me a question, tell me to slow down. So the basis for this, or the reason I'm here, or being asked to be here to deliver this talk, is because I'm heavily involved with the Royal College of Pathologists data set in the UK for reporting colorectal cancer. And I'm glad I didn't move the seats to the back. So one of the authors of this document, which really details a lot of the content of my talks today about specimen handling and specimen reporting. So this is, I was involved in the third edition of this data set back in 2014, and then again in 2018, so I could nearly recite this document word for word. I don't plan to do that today, but a lot of the content will be in there. And is this a document that's, are many of you familiar? Is this of Royal College of Pathologists? Never heard of them? Or do their data sets mean anything to pathologists in daily practice? Or is there a Polish Society of Pathology who produces data sets along these lines for guidance? There is? Okay, I'd love to see an English. That's what I should have asked for, an English translation of. That would have been useful. So that's what you probably all follow currently, isn't it? Yeah, okay, that's what I should have done in advance. So a few high-level comments just about the reasons for high-quality pathology. You have to take a step back and remember what we're doing is we're identifying patients in different prognostic groups. This is addressing colorectal cancer resection reporting. So we're trying to decide, surgeon knows about the diagnosis, but how bad or good is the prognosis for this patient based on the pathological features that we find. So we're putting it into a prognostic category. We're then trying to decide who might be appropriate to give adjuvant chemotherapy to, or very rarely adjuvant radiotherapy. And then more to do with rectal cancer, which is a lot of around the LAPCO QA process. And for those rectal cancer patients, we can give important feedback to surgeons on the likelihood of occurrence, and then also the quality of the rectal surgery and surgical specimen. And clearly, if a patient has any neoadjuvant therapy, we can give some indication of the effects that has had or has not had, and we can use, with good quality pathology, we can use the outcomes for all sorts of diagnostic and surgical audit. And just another important issue here, which we'll come back to, about when we're assessing macroscopic specimens, the importance of photography to help grade and document the claims of surgical excision for both anterior resections and non-anterior nails. So at a very practical level, this multidisciplinary team working is very, very important in all cancer disciplines, but I think in particular colorectal, there's a lot of input, as we're seeing today, from surgeons, radiologists, pathologists. They really need to talk the same language to be sure that we're managing patients in a standardised fashion and optimally. Does this process happen here? Do you have multidisciplinary team meetings or not really? No, so it hasn't. Okay, so that's interesting, because this is really a huge part. It has totally changed, in fact, the working environment for pathologists, and actually it's a very good thing, because it brings us very much front and centre stage in a clinical environment. You meet people that you've never met before, and it's the closest we get really to meeting patients. And they sure as a pathologist, we're actually doing something then, we're finding out more about individual cases, we're impacting on management, and you'll get a really good flavour for this, I hope, tomorrow in particular, where we've decided to put together basically like a virtual or artificial multidisciplinary meeting, and you can see the relative contributions of a surgeon, a radiologist and a pathologist, and how important it is, particularly in complex cases, which rectal cancer frequently throws up. So these multidisciplinary team meetings, so at a practical level, we're generally meeting for a common cancer like colorectal cancer, we're meeting every week, discussing 30, 40 patients on a list over about 2 hours, and trying to standardise the approach to management so that it's not at the whim of individual surgeons or pathologists, so that it's a standard approach to management. It goes without saying that we should be providing pathology reports that are accurate, complete, understandable and timely. And the other thing I noticed actually, which doesn't seem to be commonplace, but this is based on the few reports that I got, this data set style of reporting as opposed to free text, is that commonplace? Or, so you just type of specimen, size of specimen, site of tumour, number of nodes. Is that commonplace now? Yeah? Yeah. Some nods, some blank expressions. So variable, I suggest, seems to be the answer there. It's very, very useful for many reasons, but in particular because of completeness of data and ease of reading reports. Okay, so another very practical slide then about how do we actually get these specimens. Now I don't think there's right or wrong answers to these questions, because there are many different ways of operating a system that works successfully for receiving and processing these specimens. But what happens currently in the places you're working in? Do you tend to, so for example, a show of hands, who would get these typical colorectal surgical resection specimens? Who would get them fresh? No, all in formalin, okay. And so would the surgeon open them before they go into the formalin? Do you encourage the surgeon to open them?
No.
Does anybody encourage the surgeon to open them? Does anybody have to actively discourage the surgeon from them? Are the surgeons well trained here and they don't open them? That's it. So basically they go in, an intact specimen with feces within, into a pot of formalin that comes to the lab. Yeah? Do you tend to get them the same day or the next day?
The same day.
Yeah, so you think that's an important thing. And would you open them that day and clean them out? Yeah? I want to ask leading questions here, but this sounds like good practice. And what about how many days of fixation then prior to cutting? Maybe just 1 day or 24 hours? Yeah, anybody do longer? Anybody do 48? No? Okay. Surgeons put you under a bit of pressure to get a report out earlier, so 1 day it is. Yeah, yeah. And when you open the specimens, would you, if it's an annular tumour, would you open through it, or?
Yeah, it's dependent on tumor size.
Okay.
So we open.
If it's annular, would you might cut through it then, if it's small or big?
Annular, something we get through. If it's small, it's not our tumor, our annular.
Okay.
Another money.
Okay. And what about painting? Do you paint?
No.
No painting, not in the rectal tumours either, no? Okay.
Not in time when we acute.
Yeah, so you would assess rectal CRM, circumferential margin, just without paint, just margin looking for diathermy effect or whatever. So you assess the margin without any paint. Yeah? Okay, that's interesting. So I'll tell you what I do. With the exception of biobank specimens, we will generally get the specimens fixed. With biobank specimen, we have to sample it fresh, and I'll show you one of those later. But generally, we get them like you, fixed. It's a bit of a problem because if it's coming from a faraway hospital, we won't get it till the next day. So we make sure that hospital knows lots of formalin, please, and even then, so they're not opened and cleaned out for 24 hours after the operation, and that's not really ideal, but we get away with it. But what we've allowed surgeons to do in that hospital is actually do some tentative opening of the specimen, so we know don't go anywhere near the tumour, but because of the 24-hour delay in adding fixative, we actually allow them to tentatively open either end and try and help us clean it out a bit, and actually even put a wick in, so any sort of absorbent tissue paper or anything before going into the formalin, then that helps the formalin penetrate the centre of the specimen. Now, if you're all getting them the same day, this is better done, I think, in the pathology laboratory rather than then, because you know exactly what they've removed. But I think that's, you know, there's a bit of leeway, a bit of, it's all about communication, and so long as they don't cut through the tumour, then I think that's the biggest damage they can do. So we would generally paint, we paint both colonic and rectal specimens. I'll illustrate these later on, but especially the rectal tumours below the peritoneal reflection, so that we can assess the proximity of the tumour to the surgical resection margin. I think that's important. I'll come back to that, and I'll show you how many colours we use. What about photography? Have you any access to photography? Yeah, do you photograph all specimens, unusual ones? Has anybody not got access to?
All specimens. And before we open it, after we open it,
Yeah.
and this is.
And does this use your phone, or have you got a dedicated?
No, on the table.
Yeah, that sounds good. Does everybody get access to photography, or because I think from a LAPO point of view, photography is very important because of the quality assessment. So I had a surgeon, and when we started grading the mesorectal excision planes 5 years ago, 8 years ago, whatever it was, I got a phone call from a surgical colleague to say that if you in the nicest possible way, he said, if you ever want to call any of my mesorectal excisions anything less than perfect, I want to see photographic evidence. In other words, he doesn't want pathology grading, so no photograph, the patient's rectal, come on in, pathology room?
No, radiology.
No, you're still welcome if you want. So he said photographic evidence. So I think from the kind of impartiality or the independent nature of quality assessment, it's probably very, very important too. And this could be your opportunity, for example. So if you're in a department that doesn't have photography access, maybe you can say, because the camera doesn't have to be expensive. The camera inside a lot of these is actually just a straightforward little compact camera in a big box with a stand and legging. So it actually looks much more substantial, but as you know, you can take good photographs from with very little. So there are lots of different formal commercial solutions to camera hardware options. And you'll generally find, I think, every pathology department has got at least one pathologist that really is into photography and can provide some very easy and fundamental tips to greatly improve quality of photography. And it's amazing if you just have start to accrue in a shared network or whatever, macroscopic images, the variation in the quality of photography. So we'll show you some little very basic tips that can improve that. It's also very important because you can provide, with annotation of images, a block index of where your slides are from. But these, I think, are the most important things to actually maximise the benefit of photography. So optical versus digital zoom, if you don't fill the screen with either the whole specimen or the slices or the individual slice, when you try and zoom in afterwards on the image, then you'll get this pixelation because you're relying on digital zoom. So you want to really fill the whole screen with what you want in there, don't fill it with background. Similarly, if you're zooming, then clearly you need a scale to give somebody an idea of the size of the lesion that you're looking at. And also it's very easy to get reflections from lights, especially if the specimen and the background are wet. So clean the background, dry it with filter paper, try and turn off lights that are maybe directly going to reflect on the specimen, and that will greatly improve the quality of your photographs. I think from the point of view of QA of colorectal specimens, especially your anterior resections and abdominal perineal excisions, we should be photographing the specimen from the front and from the sides and from behind before or after slicing, and then individual slices close up to illustrate the most important points. And I find these are the images, except when the surgeon's bad quality, these are the images that surgeons like to see best at MDM. So I show very little histology now at MDMs, and I generally only show a couple of cases, and there might be something interesting or unusual about them. But from the QA purpose, we need to standardise our approach to this sort of thing, take the same photographs for every case, and if there are any issues, defects, whatever, do try and photograph those so there is a record and there's evidence, essentially. And radiologists can be very interested in correlation of these images with their findings, but that's actually easier said than done. It's quite difficult to do that. Now, this just happens to be the system that we use for photography, and no disclosures regarding financial associations or anything on my part. But we have a MacroPath system that's very straightforward. There's a camera in this, where is it? It's not what's up here. So there's a camera in here, and it's basically foot operated, which allows you to press to take the camera, to take the photographs without any issues with hygiene. So you can zoom in, zoom out and see it. That's what the 3 pedals are for. And the system is barcode read. And there's a whole lot of other bells and whistles that I don't really think are particularly important. What is useful, I'll show an image later on, is where you can actually draw little rectangles on the slices to indicate exactly where you've taken your blocks from. And if you want, you can add measurements and so on. I don't find those particularly helpful, but the block index certainly is. Okay, so this is just an outline then of the current Royal College of Pathologists data set as of about 6 months ago. So these are all the data items that we capture, and most departments around the UK will have their own subtle variation of this to fit in with the lab system, the LIMS or lab information management system they have in their unit, to try and capture all of this information. And I'm actually involved now in this international collaboration for cancer reporting, whereby similar data sets from the College of American Pathologists, the Royal College of Pathologists Australasia, and a few other countries, we're getting together and we're basically trying to do this in a standardised fashion. And this is a very, very clear-cut project that has been on the go now for about 5 years and has gone to completion in a lot of other cancers. They're only turning to colorectal now because of the issues that we'll talk about later around standardisation of approach to TNM. What system of TNM is in use. But we're looking at each one of these individual elements and then deciding, should it be a core item, should it be non-core, is there evidence that this should be reported in every case, or not? And if it is, then what are the possible responses? And the more you think about things, the trickier they become. Take differentiation, for example, so do we use a 2 or a 4 system approach to grading, and so on and so forth. We'll talk a lot more about this in the second half, or the second talk after coffee. So beforehand, I just want to concentrate in this section, which essentially is addressing all of the macroscopic elements. Okay, so this, I have now, if nobody's painting these specimens, I now have to convince you, if nothing else, from the end of the day, to start painting, and this is the reason why. So a very important bit of anatomy that's crucial to this area involves the rectum and the peritoneal reflection. So where the sigmoid colon becomes the rectum, what is peritoneal surface and what is the surgical resection margin? So it shows some actual examples of this, but just pictorially, this is the peritoneal reflection, so this is the sigmoid coming down here, looking at it from the anterior aspect. And once you get below the reflection, then you've got a surgical resection or non-peritonealized margin all around. I think what causes a bit of confusion here is the use of this term circumferential margin, because you still have a non-peritonealized margin above this level, but it's not circumferential. So there was actually a move to get rid of the word circumferential because people were referring to this margin as circumferential margin and causing a bit of confusion. So this is the posterior aspect. This is upper rectum within the sigmoid, and of course this narrows into the well-defined mesentery of the sigmoid colon. And once you get into sigmoid tumours, then it's very, very rare for this margin to ever be involved. But the upper rectal tumours will frequently approach this margin, and this is why it's important to distinguish these two anatomically. We need to distinguish between peritoneal reflection and serosal surface above, and the non-peritoneal eyes or circumferential margin below this line anteriorly and heading more proximally on the posterior aspect. So this is the bit that I think is pretty well accepted now in most national guidelines, that this should be painted to help us make an assessment of the margin when we turn this into these into slides. So this is just an actual example then. So it's slightly off center, but this is our peritoneal reflection, and we can see we've painted here below. We shouldn't paint this because this can cause confusion down the microscope. And then posteriorly, if we just spin this round, we can see this heading up the way. And so if the tumour's in here somewhere, when we slice this, we'll be able to see the circumferential margin in black. So key points: only paint the surgical margin, the non-peritoneal margin. And in terms of staging, which again we'll address more later, it's important to remember that involvement of this surface doesn't constitute an R1 resection. So there's nothing more the surgeon can do really. If the tumour is infiltrating into an adjacent organ, the anterior abdominal wall, for example, then they can, of course, take a disc of tissue there, and hopefully they'll tell us that so we can identify that when we're actually evaluating the specimen. But generally, infiltration into this surface affects the T stage but not the R status. So involvement of the serosal surface is T4 disease rather than T3. And then conversely, if tumour extends to or within 1 millimetre of, we'll talk about that 0 versus 1 millimetre again later. If tumour involves the paint or within 1 millimetre of it, then we call that circumferential margin or non-peritonealized margin involvement. And that's R1, and rarely it's R2. So maybe I'll just address the point about R2. Resection is something that I think can cause a bit of consternation and confusion. So the R2 resection generally is not a term that we will use individually as pathologists without the blessing or agreement of the surgeon, usually at one of these multidisciplinary discussions or just a one-to-one discussion. But Mark will correct me if I'm wrong, but a surgeon does not like to get an unexpected R2 designation on their specimen. It's hard enough for them to swallow an R1 without an R2. But R1 is something we can definitely, in this context, very strongly, it's a pathology call. But R2, generally, the background to TNM R status, the R is actually for residual disease. So it's interesting because when you look into the detail of it in TNM history, you actually, you read things like, if a patient has got a clear surgical resection margin on the primary excision, but they have metastatic disease, say in the liver, and that's biopsy, this wouldn't happen very often in the current era of management, but if they have another piece of tumour biopsied somewhere else and that's confirmed as metastatic tumour, strictly speaking that's R2. Now it doesn't really give the full picture, and of course the surgeon always wants to know about the resection margin in the specimen they've sent. But it's important to remember that clear margins to the patient isn't really important if they've got tumour that hasn't been removed elsewhere. So the whole patient is R2, but the primary specimen might be R0. So just communication and clarity within reports is required. The strict TNM rule is actually that the R designation should be based on the whole patient, but they've fudged it in the very latest issue of TNM 8 now basically says something like in brackets, some people use the R status to refer to the surgical specimen, others to the whole patient. So it's about clarity. Generally, I provide both in the specimen. And the important point is I wouldn't call something R2 unless I could convince the surgeon that actually, that stuff that you were cutting through and you thought or you hoped was inflammatory or fibrosis, that's actually tumour out to that margin. I think there's probably tumour left behind based on what you're telling me. Do you think that would fit with the clinical picture? And the answer is usually yes in that context. And that might impact on management down the line, possible localized radiotherapy, for example, but usually not. R2 shouldn't be a surprise to your surgeons. Okay, so what are we doing after painting? So we've got our specimen. I should say actually at this stage, back to the questionnaire answers earlier, we would always leave it 48 hours rather than 24, for the simple reason that it enhances, there's good evidence that this enhances your lymph node yield. And again, if I sort of, when I was putting this talk together, I had in the back of my mind that LAPCO assessments, standardisation, I feel slightly, I think it's important that our assessment of the specimen is as standard and uniform between sites as possible. Now, if it's 24 hours everywhere, that's fine. If it was 24 in one place and 48 in another, that might be an issue that might increase lymph node harvests completely independently of surgical technique, and that may or may not be an issue of bias in terms of assessment of surgical quality. So it's just something to think about. We leave it 48 hours because we basically demonstrated in our practice that we get higher lymph node yields in doing so. So after the 48 hours, we'll be painting it and we'll be slicing it like this with 3 or 4 millimeter thickness slices, no more than that. And then, I'll show better images that aren't quite as pixelated later. If you try and lay these out in a standard fashion, what we try and do is to match the MRI scan, so we have right, left, anterior, posterior, and then go proximal to distal along like this. But it might just, if you devise a system that's standardized, then that makes it better all around in terms of interpreting these. I'll show a specimen later on. We've been through a phase of actually using 2 coloured inks, because it's very easy to flip one of these in this direction. If you use, say, blue and black, one for right side, one for left side, then you'll always know that the blue side is right and the black side left, or vice versa. So it's important to do these things if your radiologists in particular are interested in retrospective correlation of the post-operative specimen with their pre-operative MRI scans, which is very much to be encouraged if you can offer them that facility. But of course, photography, high quality and attention to detail and painting is important to do that. So this is the sort of close-up that I think is important and that radiologists might be interested in. So we can see here, nice intact ring painted all round. So this is clearly below the reflections. This is a low rectal tumour. We can see here muscularis propria, right things onto the tumour, clearly extended beyond muscularis propria here. These little strands out here are suspicious even on naked eye examination, infection or venous invasion, and here we've got a few nodes that may or may not be involved. And this will guide where we're taking our sections from. Do any of you have access to mega blocks or whole mount processing facility? No, I mean it's something that seems to, there was a big fashion for it a few years ago, and it's great because basically you could put, maybe not a slice that size, but not far off it, you could process that whole slide in one block. So it gives you great H&E images, and I'll show you one or two later on. But actually there are issues around, it takes a separate processor, it takes a much longer processing time, so it probably adds 24 hours onto turnaround. There are issues if you want to do immunohistochemistry or histochemistry on that block. Nigh on impossible with a manual approach, so you might have to either go back and take and dissect the block and make a new one. So there are issues around this. So they look great, and generally most places that have brought it in do it for a while, produce some wonderful images, and then these sort of annoyances cause them problems, and they aren't as keen on it. But I do know for specimens, say like local excision of breast or prostatectomies, some departments are just putting basically the whole specimen through in 12 mega blocks instead of 48 ordinary blocks, and then you can see in terms of assessment of margins, measurement of tumour, how much better it is for that. And there's the kind of block, just a standard size block that would be important to take. I'll talk about what blocks to take in general, but this sort of tumour, the closest tumour to the CRM, represent that in a block, which is probably the single most important block to take. Another slice here, this is more, the tumour is more annular maybe in this section, with the exception of this area. And here we're starting to approach a little crevice in the serosal surface. So here we're getting close to the T3, T4 distinction. And these sort of areas merit considerable sampling to try and identify as many PT4s as we can. So basically that's an adverse feature independent of nodal status, obviously, if you've got serosal infiltration, that puts a patient at a higher risk of recurrent peritoneal disease, which we all know is bad news, and so we really want to try and document that if we can. So that sort of block is important to take in that case. So this is a fresh specimen, so we don't get this too often. This is actually a famous specimen because the Northern Ireland Biobank was set up about 5 years ago, and this was the first specimen that we received following it. So there definitely are advantages to the service of having a biobank, because rather than put into a bucket with a bit of formalin, hopefully plenty of formalin, but sometimes not enough, we got the specimen within an hour of the actual procedure. And so we can see it was sampled. This is just a bit of normal tissue that was taken for biobanking, and then a sample from the surface of the tumour. So notice this isn't going to compromise the tumour. What are we interested in the tumour? It's the advancing edge, it's the deep aspect of it, it's the interface with the stroma and with the circular resection margin. So actually taking a chunk of tumour here is actually fine from that point of view. And so this is an upper rectal tumour. We can see there's actually a mesorectal division here just immediately below the peritoneal reflection, and that's fine because the surgeon has got 5 centimetres beyond the lower edge of it, so that's fine. It's very unusual. We wouldn't often open the specimen anteriorly, but so I did this one myself, and so normally we might cut it down to here, and I wasn't sure how we were going to approach biobanking in general, but for this one we thought I could actually palpate once we got to this level when the whole specimen was intact. I could palpate anteriorly and confidently feel normal mucosa, and I thought this isn't going to compromise anything if I cut through this. But if the tumour was circumferential, it most certainly would compromise your assessment here of the serosal surface, or if it was lower down, assessment of the CRM. So generally, in an annular tumour, we would never do this. It's quite rare to get one where you can actually palpate down to there. So generally, we would probably just open to about here, and then pass a wick through, and then put into a fix for 40 hours at that stage. So this was unusual for a couple of reasons. It's a biobank case, so we were sampling it, and it was received fresh and opened anteriorly. So don't show this photograph to non-surgical, non-pathology audiences. This is a bit too close to them. So this is what we're sectioning after fixation. This is the same case. You can see, so it's open here because of that anterior cut that I made. And so I painted this one. Right hand side was green, black was left, and posterior blue. Don't ask me why. You can do these things differently, and they work. You can see the tumour infiltrated beyond muscular astrocyte here, and the suspicious node is quite close to the CRM, but looks just about clear. What I see now is probably worth mentioning back to R1. So if you have a node that's involved, or indeed venous invasion, and it's close to the resection margin, it's a tricky situation because the strict TNM rules are that if the node involved is within 1 millimetre of the CRM, then technically, applying their guidelines, that's an R1 resection. It's something I really struggle to apply. I must say, if this node is involved, I don't see how that, and let's assume that there's probably a couple of millimetres. If that is less than a millimetre, I would find it very hard to call that R1, because if the node looks intact, TNM is sufficiently vague that it doesn't actually give you an indication like, well, is it the edge of the lymph node that you measure to the margin, or is it the closest tumour cells within that lymph node to the margin? So when you start to burrow down for detail, you find reasons not to call this R1. So I try and avoid that scenario, unless of course the node is transected and involved. That's how I transect. Okay, so the sampling. What sampling do we go for as standard? So we would now take at least 5 blocks of the primary tumour. The reason this seems to creep up with every iteration of the data set, and I think it's because we're more and more interested in things that are around the vicinity of the advancing tumour edge, where we're interested in, that's where you're likely to see venous invasion, or maybe assess stroma and inflammation, and it's gathering momentum regarding important factors, tumour budding, which isn't a core item, but as you've probably all heard of. Does anybody report tumour budding here routinely, or what's the Polish Society's viewpoint on that currently? Is it reported or not, do you know, buddy? Gathering that's a no. Yeah, so that's not something, there's a lot of evidence of its applicability, but because there isn't really good evidence following standardisation of the testing method, then it's not something that I think is in routine practice yet, and certainly I'm not a big fan because the reproducibility of it is pretty poor. So the blocks that we're taking, we're trying to demonstrate deepest penetration beyond muscularis propria, any potential or clear-cut involvement of the peritoneal surface, anything that macroscopically we might think is suspicious of extramural venous invasion, involvement clearly if there's any adjacent organs attached as an en-bloc fashion. Rarely you might get a bit of stomach, for example, or posterior vaginal wall or bladder or whatever, anything that we clearly want to document. And it's also a good idea to take a block that is as pure tumour as possible, pure solid well-fixed tumour, because that will give you the best block for molecular testing down the line. So, yeah, I think I've said this already. Basically, it's clearly important that you want to document the closest aspect of tumour to all margins, not just the circumferential margin, but say you've got a very low rectal tumour and that's very close to the distal mucosal margin, you might want to shave that distal margin, especially if there's no anastomotic rings about it, and then maybe take a perpendicular slice to demonstrate involvement. But you don't really need to do that unless it's, say, less than 3 centimetres or so from the margin. So, sampling for these two very important adverse features, T4 disease or EMVI, we really should be guided by macroscopic assessment. You can often see these little strands travelling perpendicular to the advancing tumour edge, and that's where to go looking for extramural venous invasion. And similarly, if you see indrawing of the serosa or puckering, then there's clear-cut or extensive sampling of those areas, like here, for example, might have shown this earlier. This is where we're actually trying to demonstrate, or most likely to demonstrate, T4 disease. Okay, so very text-heavy slide, sorry about that, but this is straight from our document guidance, and I think this is very important when we think about, again, quality assessments. We touched upon it earlier, that how important it is to standardise our approach to lymph node dissection so that we don't have we remove as many factors as we can that are related to pathology and variation of the lymph node yield. So, for example, I would be trying very hard to avoid a situation where you have pathologists going back to the specimen to look for more nodes because the original harvest was only 6 or 8 or 10 or 12. And you want to have confidence in the original dissection. And I often get asked, or not so much now, but I used to get asked, do I return to the specimen if you only get, say, 8 lymph nodes in it? And I say, what I do is I look at the size of those 8 lymph nodes, and if the smallest one of those nodes is about 1 centimetre, then that suggests to me that there's probably a lot smaller lymph nodes left behind. But generally, when you report a case that only has 8 lymph nodes in it, what size are those lymph nodes? They're a couple of millimetres. This just happens to be a patient with a poor immune response, often elderly patients, maybe following neoadjuvant therapy. So if those 8 nodes are 1 to 2 millimetres, and there's probably maybe an awful lot of what I would call squeezed fat, or you put in blocks of fat that is just basically little vascular bits of tissue that may or may not show more tiny nodes. When that's been done, then I know that the specimen has been exhaustively searched for. And I'm actually much more worried about a specimen where somebody has found 15 nodes, but they're all 1 centimetre. And if they're all clear, that's the kind of case that worries me, that there isn't an involved node left behind, because you can rest assured if you go back in that setting, you can find another 30 nodes if you want to. But somebody's dissected it, thought that met their minimum count of 12 with a bonus of 3, got to 15 and thought they'd done a good job. But the single biggest disservice I think we can do to a patient with a pathology dissection is to miss an involved lymph node and deprive them potentially of adjuvant chemotherapy. So this, no apologies for dwelling on this. We need to spend a long time. It's possibly the most boring aspect of colorectal pathology for pathologists, the lymph node dissection, but also the most important. So having identified all the nodes, then we need to then ask the next question, what about processing of them? So there's some countries and some centres that advocate processing all of each lymph node in separate cassettes, and then there are other places that just sample the nodes. What do you do? Separate cassettes, all node in separate cassettes? No, some do, some don't. Okay, who puts in all of the nodes in separate cassettes? And who just samples the nodes? Right, so that's interesting. So we just sample them, and the guidance says sample. So this is for a node that's maybe over 5-6 millimeters. What we'll maybe do is trim off the edges and have a nice slice down the middle that's going to be 3 or 4 millimeters. And we might then, and then if it's a smaller node, we'll probably put those in intact, but we'll probably put in maybe 4 lymph nodes per cassette. And so there will be bits of nodal tissue that aren't processed. And so obviously the more you put in, you might say, well, you know, the more, you know, you could be missing tissue, you could be missing a small net if you don't put it in. But I would say that, well, even if you do process the whole node, how many sections do you look at? Do you do immunohistochemistry to help that? You know, there's always a sampling, I think, a sampling issue in pretty much everything we do in pathology. And the number of, how many cassettes are in one of your cases? How many blocks are in one of your colorectal cancer sections? 20, 30. And I'm guessing those that do what we do and only put in, you know, 4 lymph nodes per cassette is probably more like 15, 20. So it probably increases the number of blocks by at least 50%. I wish we could cope with that workload increase. But I mean, it's not a black and white thing, because there's another school of thought that said, well, that's such a cheap thing to do in the grand scheme of the whole patient management line, that there's a bit of momentum, and there's some very soft evidence out there that say, you know, of course, I think in practice, what does it do? You put in more, you find a few more mets. Does it ever materially impact on the actual end stage? Possibly it might increase somebody up a notch, but I don't know that I've ever come across even like an N0 to an N1. You know, I think it's yeah. So I think it's an ideal practice, but we consider there not to be sufficient evidence for us to recommend doing that. And so we just put through slices of largest nodes. But again, I suppose it's not actually going to affect your lymph node counts. I'm thinking of the LAPCO QA process here, that it's not actually affecting the nodal count, which is probably the most important thing. So the most important thing is the standardization of dissection, to make sure you're getting all the nodes first time, and there's not a practice of going back to specimens to do it properly. So the pathology of dissection should be done properly up front, and then when you issue a case, there'll be 6 or 8 nodes in it. If your median nodal count for the department, an individual pathologist or the sector, is over 12, then there should be no issues there. Fat clearing agents to increase nodal yields. Do any of you do that? No. I mean, we don't do it either, but again, some places do. But we did find, in fact, it was this that got us to, we were auditing this versus the 24 and 48 hour fixation, and this is where we found that actually this didn't really improve the yield, maybe a few absolute tiny nodes, very messy. It dissolves all the fat into an oily, it's like working with a chip pad nearly, or something that's really, really terrible stuff. But the 24 to 48 hour fixation plus did make a difference. Basically, you're getting better fixation, and you're better able to palpate these little 3 or 4 millimeter nodes. So following that sort of audit, we decided not to use any fat clearing agents. And again, I'm glad that it would potentially be an issue for NAPCO if half of you were using fat clearing agents and half of you weren't. That could be another kind of variable that might be influencing nodal yield. So standardization of approach to dissection, lymph node identification and processing is important. Okay, before I launch into this section, which is quite substantial, are there any questions on anything that I've covered so far on the kind of practical basics of specimen handling? Okay. So this QA assessment is probably the most important thing And then notice I was gratified to see in some of the reports sent through that this seems to be done at the minute, in at least some centres. Is everybody doing this at the minute? Assessing TME? Yeah. Anybody not doing it and wants to admit it? Okay, so that's good. So I think it's important because I think this is the single most important aspect that we can apply to LAPCO because of the issues around lymph node counts that we talked about, and we'll talk about CRM involvement later, but I think this is very important, a bit of history and how this is developed or how it came about is important. So you've already heard these two gentlemen mentioned in Mark's introduction, and you can see how long this has been around. So this is Professor Phil Quirk, who's one of my co-authors on the Royal College of Pathologists data set for colorectal cancer, and he's been involved since the early days in that data set. And way back in 1986, he started to look at recurrence of rectal cancer in association with CRM margin involvement, and basically demonstrated that involvement of the margin was significantly impacted on likelihood of recurrence. And this was around the same time as Bill Healy was starting to put forward this total mesorectal incision for TME surgery as the standard and optimal surgery for rectal cancer. So only small numbers of patients in this study, but Phil showed that of the 13 patients with the positive CRM, 11 of those recurred, whereas only one recurred out of 38 when CRM was clear, and they defined that as 1 millimetre or less involvement. And so now, if we fast forward many years, there's an awful lot of evidence that shows we can assess the margin and give very powerful indication of likelihood of recurrence. So it impacts both the development of distal metastatic disease and survival, and the importance of the focus on margin involvement in rectal cancer is now very much established. So the introduction of TME surgery into various units or nations has brought about significant impact on survival. So here in Sweden, for example, you see that following the introduction of TME surgery, the cancer-specific survival increased quite significantly. And this has been replicated in many other places. So also as part of the CR07 trial, it was demonstrated that if you feed back the planes of surgery to the surgeon, then that actually improves the quality of surgery. So over the years of recruitment into this trial, this is CRM positivity rate, which started off at about 22%, and 5 years later it was down to 10% or less. And this was heavily due to improvement in surgical quality helped by feeding back the plane of surgery to the surgeons. So the rationale behind TME surgery, so this is one of these whole section mounts that I was telling you about. So we have, I think this was a tumour post chemoradiotherapy, so it's nearly all disappeared. So, but this is an intact mesorectum, and I'm just illustrating here all the different structures, the small blood vessels, little lymph nodes, there'll be nerves in here as well. So all these different pathways that we'll in fact talk about later in TNM8 assessment. But this is what we're trying to take out intact, this mesorectal envelope, so that should tumour be engaging any of these pathways, we're not disrupting this. Now here this is all quite clean, there's no tumour in it, but you can see how if there was tumour involving the mesorectum, how incision into this, or worse still all the way down to muscularis propria, might expose tumour to margins and therefore increase the risk of recurrence. So that's really the theory of TME surgery. And then the grading, it was really shown that in 2009 by Phil and others, that assessment of the grade, and I'll show these in better illuminated images later. So this is the optimal mesorectal plane, this is the intramesorectal with our incisions, and this is exposure of muscularis propria. So in those that had a muscularis propria plane of excision, the rate of local recurrence was significantly higher than the other two combined. And again, like the CRM involvement rate, the years of this trial showed that there was an increase in the quality of the grading with feedback of the actual grade to the surgeons doing these operations. So this educational feedback is important. And this Dutch study showed that they were able to train pathologists in the assessment of the grading. I think this is important with workshops and illustrations and videos. They trained a cohort of pathologists to do this locally, and this was able to, they were able to extrapolate the same data to indicate that this was significant in this study. So 24% the mesorectum was incomplete, and these patients had an increased risk for local and distal recurrence compared to those with a complete mesorectum. One thing you might notice is evolving terminology or different wording used for this assessment in different places. What we've moved to in the UK is kind of the least judgmental, if you want, terminology for this. So we basically define plane of surgery. We're not making an assessment of quality by direct descriptors, because of course there could be a very good reason. So like an advanced tumour that's got neoadjuvant chemoradiotherapy and then shrunk, but of course a lot of fibrosis, and that might be a very good reason why the surgeon has been unable to achieve a good mesorectal plane of excision. So to call them some of the terminologies used in some countries for this assessment is a little bit judgmental, and I think sticking to anatomical planes of excision is probably the most appropriate. And here's a meta-analysis, I think, of over 4,000 patients, again just documenting convincingly that the increase of local recurrence and overall recurrence was much higher for those with suboptimal TME dissection. So this is what we're trying to do. We're trying to basically assess the intact mesorectum. So this is the posterior aspect, because you see the line peritoneal reflection going up here, and this is what we're hoping to see in all cases, this nice intact mesorectum with a shiny surface, good symmetry usually, and good bulk of tissue on either side. If we see defects in the wall, it's a lot easier to when you have these specimens in your hand, and actually this illustration doesn't really show it particularly well, but you're looking for defects basically in the wall of the mesorectum, and this is the sort of thing that if you're going to call something intramesorectal or muscularis propria, then you're going to actually want to document it with a photograph. So it's basically incisions in the mesorectum. So that's intramesorectal, and then if there's very little bulk, so you can see exposed muscularis propria. This is muscle tissue, so there's very little mesorectum here. Clearly the surgeon has left most of the mesorectum behind, and this is the muscularis propria plane of dissection, which thankfully we don't see too often. Does that tally with what you're doing currently? Most of you said that you were assessing these specimens. And so then moving on to abdominal perineal excision. So this is the operation of choice for most low rectal tumours. And we see that this is a different animal, because once we get down lower, then the risk of CRM involvement and perforation is much higher than those for higher rectal tumours. So the standard operation here is abdominal perineal, and we can see because of the increased risk associated with this operation, there's a higher percentage with local recurrence and a worse overall survival compared to a low anterior resection. This is the standard abdominal perineal resection with the waist being ears be down into the pelvis, and this was the standard operation for quite a while. But if we look at a potential problem with this, is that the line of dissection that the surgeon is trying to follow is this yellow line, but it's pretty difficult as they get down low into the pelvis to maintain this line, and it's easy to migrate medially and actually dissect into the sphincters or cause an actual perforation. So this demonstrates an old case where the line of dissection is really into submucosa. This is in non-intact muscularis propria. So actually the CRM of this specimen is formed by submucosal tissue, which is clearly inappropriate. And this is only a PT2 tumour, but R1, and that shouldn't really happen. We should be trying to you should be able to achieve a clear margin, and we can see a full thickness defect here. So a PT2 R1 shouldn't really happen. So So the proposed solution to this is the more extensive extralevator or cylindrical abdominal perineal excision, and this is not a new operation, as you can see, it's been suggested over 100 years ago. There have been different terminologies used to describe this kind of operation, but essentially it's just more extensive resection and trying to maximise the chance of getting a clear margin. So the extralevator dissection can start off here and then join from above to produce this type of specimen without the wasting of the end of conventional abdominal perineum. And this has been shown to have lower risk of margin involvement and lower risk of recurrence. And then Phil Quirk has gone further and now tried to grade these specimens and see can we apply the same methods for TME evaluation to the abdominal perineal excision and feed this information back to surgeons and see does it have impact. So this is what we're looking for, the levator plane of surgery, where we actually have the levators plastered over the surface. And this is our nice cylindrical specimen. Here we have the classical wasting, the sphincteric plane, and the intrasphincteric if we have a perforation in the specimen or dissection into the actual sphincteric complex. So a Dutch group were the first to report outcomes in this. So in an AP series, they have looked at the evaluation of both the mesorectum and the sphincters. And so at the time of this study, there was no extralevator surgery going on, so 0% here, and only 10% were actually achieving the TME plane of surgery. And then a few years later, in 2012, another Dutch group, the ELAP study, at this stage, the extralevator surgery was more popular, and over 50% were getting that. And the TME evaluation provided a much higher level in the mesorectal plane. But even with that, there were still only 30% achieving the perfect mesorectal plane for TME and extralevator sphincter dissection. Importantly, and we'll come back to this later on, that if you, as pathologists, can agree, or if we can agree on our assessments, then we can offer a tool that might be clinically useful. But if we can't do this, if we can't standardise our assessments, then actually to use it as a tool to evaluate quality elsewhere is questionable. But this showed good, or at least moderate agreement of the assessment. So what about colonic cancer? Can we apply any of these principles to colonic surgery? This is a slide demonstrating survival after colon cancer in a large number of NHS trusts in England. So we see, you know, you have a potential problem if you have significant differences here. So this trust, their patients were doing an awful lot better than down here. So if there's significant variations in outcomes, once you've excluded things like case selection bias, or means it's a referral centre, they're only getting difficult cases, for example. If you've excluded that and there's the same type of cohort of patients, then there might be an issue with surgical quality. So the next thing coming in is around CME, or complete mesocolon excision for colonic cancer. So again, the same principles that looking at in rectal cancer, can we apply those to the colon and see if we can derive any of the same benefits. So there's been a lot of work done from Leeds Group in this, comparing surgery in Japan and Germany and the UK, and demonstrating that improving the quality and feeding back to surgeons on the type of operation they're doing can influence outcome in relation to disease-free survival. But importantly, for this assessment, we haven't yet been able to devise an evaluation system that we are confident pathologists can do reproducibly. And I think this is fair enough. I mean, I find it personally a lot more difficult. Maybe something that's very objective, like a measurement of the maximum length of the mesorectum submitted, for example, something that might be easier. But actually grading these I find very difficult compared to grading the rectal anterior resection. So this is not in use yet. And most of the major data sets globally, the only evaluation that's there in them all is this TME evaluation, and that's in the RC path, the CAP and the RCPA guidelines. The orthopath has got the AP or sphincter assessment, but that's not on the other two. Nobody's evaluating mesocolic incisions at the minute. So these are standards that we apply to pathology practice, and this is undergone a slight modification because of introduction of bioscreening programs and extensive use of neoadjuvant therapy in most cases of rectal cancer now. So the current standards that we are auditing, or most departments audit for the pathology practice, is the median number of lymph nodes, and usually at least 50 cases non-screening, because obviously a screening population may have a different number of nodes. You could argue that they're earlier stage and probably smaller numbers of lymph nodes to be expected in those. Frequency of peritoneal involvement in colonic cancer, again we should exclude rectal here because of the preoperative therapy might influence that. And then EMVI, which should be at least 30%. So again, we're just trying to make sure that these important parameters are picked up in an appropriate number of patients. But can we apply any standards to surgical assessment for the purposes of LabPro? Well, when I was asked this question, I thought the obvious place to go was to see what standards there were applied to pathology practice within trials that compared laparoscopic to open rectal surgery. So there's a lot of repetition in these. Basically, the same issues kept coming up: number of resected lymph nodes, assessment of surgical margins. In this one, this is all meta-analysis data. Lymph node harvest, distal margin resection, CRM margin involvement. Similar down here, lymph nodes, surgery, mesorectal fascia integrity. So that popped up. And I concluded that I thought these were the three standards that we could probably best assess reproducibly and were perhaps of most relevance to the LabPro project: lymph node counts, or Loughrey and TME assessment. So to just summarise this talk, I think standardisation of specimen handling and dissection, especially with respect to lymph nodes, is of particular importance. Photography is something that I think we don't take as much care of or pay as much attention to. And often when I go back and look for photographs for a particular reason or case, that's of course the one where the quality isn't optimal. When we get into and try and introduce a nice standardised approach to specimen photography with quality and nature photographs, that's a good service improvement that should be easily attainable. And then as the proposed assessments of surgical quality may be relevance for a LabPro project, these are the three factors that I think we might be looking at. So Cuthbert-Jukes came out with this famous phrase many decades ago, that we shouldn't choose the operation, but we should choose the surgeon to do it, and choose the surgeon with great care. But maybe in this day and age, you should also focus on ourselves as well. Okay, 5 to 4. Any questions on that? Have you heard all that before, or is that any of that new to you? There's something new in there. So maybe just before coffee, what I might do, how well this will work, but I just put a whole lot of images of. I thought probably the thing that's maybe mostly of standardisation or assessment is the TME evaluation. So these are random sets of images from TME evaluations, and just to show you the kind of thing. So say they're unselected. It's very hard, I think, in our service now to find a muscularis appropriate plane of dissection, but just to show you the kind of things. This is actually a bit like the fresh specimen we sent in, so this is clearly a high rectal, almost rectal sigmoid tumour photographed anteriorly, and you can see this puckering in here This is probably where it could easily be early T4 disease. Oops. And so slicing through that area, we can see that this annular tumour, this is the kind of place where I would be taking 3 or 4 blocks to try and demonstrate early T4 disease. Suspicious looking lymph node found here as well. But I think that's a mesorectal gain of excision. That's enough quality, just that's, I think, another nice mesorectal plane of excision. This one was painted black along one side, blue on the other. And then when we cut into it, we can see that the tumour looks quite an early tumour here, probably P2, PT2, and well here with margins, so it looks like a good news one. This is what I meant by the using the photography software to generate this block index. So this is very quick and easy to do, and the software automatically adds the lettering just with a little click. So we can see it's taken 2 blocks from this section, another one here, 2 more here, 2 more here, probably one on top of the other because the slices are maybe closer to a centimetre thick. And then this, you can correlate this with the slides that you're seeing histologically. Let's see if we can find anything else. So here's a less than perfect specimen. And this patient had radiotherapy, and I think it was quite a locally advanced tumour, at least it was before the therapy. And you can see these big defects. Now this is APR, but this is upper mesorectal level here, and these big defects in the specimen. This was graded as a muscularis appropriate plane because there was exposure of the muscularis here. So again, when you're pulling something like that, it's good to take a close-up image so that you have evidence. And this will obviously translate when we get to the rings. And you'll see that there's very little bulk to the mesorectum at several points here, and it's like the specimen was quite disintegrated. And again, there's our block index. Here's an example of one where that I would call bad photography, where we have, I'm not even sure what this is. I think the wrong image. That's really bad photography for an APR. I think the wrong images have copied across there. Any ideas what that might be? I'm not even sure that's a GI specimen. Oh, that's a, unfortunately illustrated that, but the images that I hope to show there in the specimen wasn't filling the screen, it wasn't clean background, and the focus was on the ruler rather than the specimen itself. And I think this one, just to complete the grading assessment, this one was a single defect. You can see how the surgeon has cut into the mesorectum here, but it's, it can sort of fold back over again. This is the kind of one I would call intramesorectal, but the rest of it was all fine. Nice gut posteriorly, and this wasn't a big issue because, as you can see, the tumour was quite an exophytic lesion, and this was, I think this might be, looks like a PT1 on that basis, and so the end didn't make any difference. Okay, I don't know how useful it is for you to see those images, but that's the kind of grading that we do, it's a fairly standard assessment. Those are the kind of photographs we take. and we try and do that in all cases, and these are then saved in protected network files so that we've got a permanent record should anybody want to evaluate it. Any questions on any aspect of that talk? So how close or how different, are there any, what's the biggest aspect there that I've spoken about that would differ from what you're doing currently? Or is it just exactly? Very similar?
Very similar, but rather taking photographs also.
Okay. And I would have thought of the other things, the inking. Are you persuaded that it's worth inking these things, or not? Still not worth it? The painting of the specimen? I think it is. I think it is definitely worth doing, because you can identify serosa histologically, which is going on the mesothelial thymine, but the CRM, I don't think you can confidently say some margin of how I think. Okay, well we'll maybe take a break there then, and stretch your legs and get a bit of air or coffee or whatever you want, and we'll see you.